are actually some new opportunities with these new delivery models. New payments. We came up with a type of payment that is for quality called the quality value unit. When I was giving these lectures a few years ago, I would typically say fee-for-service is a problem, capitation or employment solves some of that, and we'll get in that in a minute. But what I realized later was the part of fee-for-service that was a little problematic was the RVU. That's 20 years old or more, and it's good for the 15-minute visit or the surgery sometimes, although people argue, but it doesn't give any value or any payment for checking a registry, for addressing 5 chronic conditions when 1 acute one will get your level 3 visit, or making a different referral or calling a case manager. No value in the RVU system. So we invented quality value units that were, and we use them as a method of payment. We're actually involved in a possible CMS grant to look at that as a way of paying on top of RVUs, and a way of getting the behaviors that you want. Our ACO is made up of independent practices, centralized data. This was new. This wasn't in the HMOs of the 80s. We handle the compliance, and we give local control of the clinical decisions. So you decide, not centrally, locally you decide what gets done. We have care coordination and education as needed. No initial cost by the groups. The tools and clinical support are free, and this is our new improvement, which is the QVU payment, meaning why not pay for the behavior that leads to the quality? So now, payment considerations. Fee-for-service, RVU-based. It doesn't account for quality differences. It doesn't necessarily reward prevention. As I said, I could do a lot of prevention, but the RVU doesn't count it. No reward for efficiency or savings. Doesn't reward care coordination, and may reward adverse effects. In fact, I'm not saying we do this, but if someone gets sicker and there are more visits, you get more RVUs, or a hospital gets more admissions. So when we look at ethics, there is actually an ethical incentive to not necessarily do prevention or make people better. Capitation, not perfect either. So it may account for quality differences and reward some prevention, and you do get some savings. It doesn't always reward for these. Problem is, one practitioner may do a whole lot of the good behaviors and another may not. That's why we came up with the QVUs. Global payments account for and should reward quality, actually, because you have to pay for the whole population, you should pay attention for prevention the most with a global payment. It does reward efficiency and some care coordination. And again, it may help with innovation and may be the way of the future. I think if done well with safeguards, these types of payment models, which even changes in the SJR may make it more likely that we're going to sign up for one. I think that these have potential. The QVUs are, we think, better than RVUs in a global system and are designed to give providers extra payment. They track and report real time, meaning you don't wait for the quality outcome a year from now or the savings. Get paid this week. Provide quality tracking and budget tracking.